Welcome to the Dementia Care on Air podcast series. I'm your host, Anna Chodos, the Executive Director of Dementia Care Aware. The goal of this podcast series is to bring you short, educational moments that will help you detect dementia and care for people living with dementia. And we're especially focused on how we do that in the primary care environment in the real world. We're going to have a lot of information that mimics what we have on our website and in our other educational modules. But we're also going to have conversations with experts and other people in the community in the field of dementia care that just help us do a better job of caring for people living with dementia and connecting them and their care partners to the things they need. Good afternoon and hello, everyone. Thank you for joining us. And I'm really pleased to be joined by my incredible colleague here at UCSF, Dr. Tanisha Hill-Jarrett, who's an assistant professor at the UCSF Memory and Aging Center. You may have already seen our webinar with her on dementia and the African American population. We're also joined by Dr. Charles Winden, who we'll be talking to later about his part of the presentation. But I'm really glad to be really just focused on Dr. Hill-Jarrett's work today and to give her a chance to describe her work and where it's going. I think probably if you saw our webinar, which I encourage you to go back to our website and take a look at, you'll really appreciate how much she's moving things forward in terms of our understanding and our ability to address disparities in dementia and dementia care for African American and Black adults. I am going to say Black adults throughout the rest of the podcast, and I'm now going to welcome my guest and ask that she please introduce herself. So thank you so much for joining me.
Hi, thank you for that kind introduction. So my name's Tanisha Hill-Jarrett. I'm a neuropsychologist and an assistant professor at the UCSF Memory and Aging Center, and I do clinical work with older adults as well as research and focus primarily on psychosocial stressors as well as structural level barriers that Black women experience and how that may be linked to risk for Alzheimer's disease and related dementias.
So why don't we start out? I just want to ask if you can sort of level set with us and help us get back in the mindset and basically on the same page about what we're talking about when we talk about social determinants of health, especially as you mentioned in the world of brain health and dementia, and especially for Black adults.
Sure. So the social determinants of health are non-biological factors that impact a person's health and their health outcome. So these are the environments that we live in, that we work in, that we age and grow old in. And ideally, addressing these things are key to reducing disparities in cognitive aging. And so some common examples of the social determinants of health are things like your neighborhood, so lived environment, physical environment, whether or not a person has housing, whether there's green space in their environment, whether there's access to healthy foods and a grocery store in their environment. Other examples are things like education, quality of education in particular, as well as healthcare access is another good example. Community and social context is also a key determinant of a person's health and cognitive aging.
And what do we know about how those things, like what's the state of the science and how those things affect brain health?
So what we see is that specific groups of people have differential access to these determinants of health. So differential access to quality education, differential access to healthcare, things that downstream shape our actual health and health outcomes. And so this differential access across different groups, so across race, across sex and gender, this in turn contributes to what's called a healthcare disparity.
And I know you've done some research and are going to do more research on like how we really understand how those things are impacting dementia rates or diagnosis, or I guess cognitive aging. And I guess can you share some of what you've learned or what you think is some of the most interesting findings?
So one thing I think It's important. So I've talked about the social determinants of health, how that's linked to a person's health outcomes and how they're considered upstream factors. But I think it's also really important to go even further upstream, looking at the structural level factors. So things like structural racism and how that manifests in society, structural sexism, as well as the political determinants of health. And I think a really good way of thinking about this and a more modern day example of this is thinking about how policy, so Brown versus Board of Education, has shaped access to education and how education is really critical for the development of things like cognitive reserve, which we know is critical for buffering against cognitive decline and incident Alzheimer's disease. And so with Brown versus Board of Education, essentially, it integrated the education system. And so this was passed in 1957. And prior to that, schools were segregated, and schools, particularly in southern regions of the United States. And what we saw was that there were drastic differences in the quality of education that Black Americans received. And so oftentimes Black Americans, there were a high number of students within a classroom. So the student to teacher ratio was really high. They didn't have the access to the same quality books. Oftentimes, students actually had to leave school to work. And so they weren't even present to obtain the education that they were supposed to. And so how this manifests in present day, so the people that were subjected to these laws actually are now in their 70s and 80s. And so what we're seeing is that these differences in quality of education are impacting actually our estimates of cognitive reserve. And so what we're seeing is that education is not contributing in the same way to cognitive reserve for people of racial and ethnic minority backgrounds. And the thought is, so basically, 12 years of education is not the same thing. It doesn't equate across everybody. And so really what we're seeing is that it's about quality. And so essentially things like literacy really get at that, et cetera.
Okay, that's really an interesting point because basically, clinically, a lot of times we're just saying, how far did you go in school? Using that as like, I know for myself, if I'm trying to do more objective testing or something like that, whatever I can do, let's say bedside is would be my version as a medical doctor. But a MOCA, for example, like we split that between people who have a high school education and people who don't. And so they might get a MOCA basic or something if they don't have a high school education. But the point you're making is that might not be a fair comparison. And I think there was a recent study that kind of pointed out some of the challenges with the MOCA in different minoritized populations compared to essentially mostly white populations. And so, yeah, clinically, I mean, you're probably always you have the tools at your disposal as a neuropsychologist, but clinically, is there something that you sort of wish most providers knew to ask? Like, tell me more about your schooling.
Yeah, getting a detailed history about education, asking about where they actually were educated, asking about why. Maybe if, for instance, they didn't complete high school, sometimes people just say didn't graduate, right? So first of all, getting the grade that they actually completed, but also figuring out why they were no longer in school. Was it because they had to work, et cetera? I think those are all actually really, really important to follow up with and contextualizes their experience so that we know how to make sense. Particularly, I'm thinking from like a cognitive testing standpoint, so that we know how to make sense and interpret their data. The other really, I think, important thing is, and this is what's, I think, more strongly linked to education quality, is literacy. And so when we do assessments, we ask people to read a list of words, but they're not words that you can phonetically sound out. They're words that you would have to have exposure to education to, like yacht, right? For instance, if you try to pronounce yacht, it's not how it's spelled. And so it's things that only you would only know through educational experience. And so we look at literacy kind of as a proxy for a person's actual education level. And that's a better indicator than actually looking at years of education.
And the other really important thing I think you were talking about that I'd love to understand more too is this idea of cognitive reserve and how kind of as you were talking, I was imagining, whole groups of people just not having access to building that cognitive reserve. I just wanted to ask if there was another, a certain way to think about cognitive reserve and how that gets built and how these social, structural, political determinants of health are affecting that.
So, cognitive reserve is thought to be a buffer against the pathology that accumulates when a person has Alzheimer's disease. And so, the thought is that two people can have the same level of underlying pathology, but the person with higher cognitive reserve actually, it takes longer, or they have to kind of experience a higher burden of pathology before they manifest actual clinical symptoms of dementia. And so it's thought to be, yeah, this buffer against the neuropathology that people develop when they develop disease. And so ways that you can build cognitive reserve, so education, as I mentioned, but also through experiences. So occupational complexity is a way to build cognitive reserve. Doing novel things and learning new things, even outside of kind of an academic context, is also critical for building cognitive reserve. And what we see is, because of these structures and systems that are in place, people from disadvantaged backgrounds don't have the same opportunities to have complex occupations, may not have the same opportunities to have these experiences that build cognitive reserve, which kind of feeds back into, okay, based on the quality of your lived experience as well as your educational experience, you're not given the same opportunity to develop reserve essentially in the same way.
That was really interesting. I want to touch on something else you mentioned during your talk, which was also sort of the role of people's experiences getting healthcare and their approach to getting healthcare, experienced differently based on race and ethnicity. And yeah, just sort of talk about some of your work in that area and what you've learned.
Yes. So there's also, we know that there are disparities in access to clinical care and quality clinical care. And a lot of my work, I think, was driven by some of a recent survey by the Alzheimer's Association, which basically showed that about 50% of Black Americans that they surveyed reported experiencing discrimination, particularly when attempting to receive healthcare for dementia. So that was one thing. And then the other thing I think that really stood out was from the survey with the Alzheimer's Association was that only about 50% of Black Americans believed that if there were a cure for Alzheimer's disease, that it would be distributed fairly. So not only are Black Americans experiencing discrimination, but they're also concerned for the future, right? So in real time, they're experiencing this discrimination, but they're also wondering, what does this mean for the future of my healthcare? And so what I was interested in was looking at whether experiences at an interpersonal, individual level of discrimination would predict whether or not people would want a hypothetical test that would tell them whether or not they would develop Alzheimer's disease. And so what I did was I looked at this with data from the Health and Retirement Study, and it's with individuals who are 51 years or older, so particularly amongst older adults. And they were given a survey and asked if you could receive a test that was free of charge that would tell you within the next 5 years. So people were put in a group that said 5 years, and then in the near future, they were also asked that whether or not they would develop Alzheimer's disease, would you want this test? They also completed a survey that asked them about their experiences of discrimination. And what I looked at was the association. So whether or not experiencing discrimination actually predicted their interest in receiving this hypothetical test. I looked at this across different racial and ethnic groups. I also looked across different socioeconomic groups, or whether or not they experienced discrimination because of their socioeconomic status, and then whether or not they experienced discrimination because of their gender. And essentially what I found was that experiences of discrimination was not associated with people's interest in this test. And actually about 80% of the sample expressed interest in wanting to receive this test. And of those people that expressed interest, they were actually more likely to come from a racial and ethnic minority background. And I think that this is really important because when we think about some of the barriers and talk about the barriers to providing equitable care and making sure people from minoritized backgrounds are getting the care that they deserve, oftentimes the blame is placed on the individual as if the people from these backgrounds aren't interested. And actually what this data is showing is that they are interested, and it's not an individual preference problem, that there's likely larger structural and systems level problems that are impacting their ability to get into the system to get the care that they deserve.
It's also a very motivating finding. I'll just speak personally because, sometimes when we see the data on structural or, larger systemic barriers to healthcare and, the way things are kind of built and difficult and structured to really discriminate, you just get overwhelmed. But I think we all have the experience of caring for people, and to know that it's certainly more likely than not that they want care or access to these things is really, really motivating to me, especially working in a system where often we get things later than, maybe some of the academic centers or places that are, working with trials and things like that. Like, we're going to get those interventions or those latest things later. Sometimes that can be good because we see kind of if they're safe or not, but it really motivates me to make sure everybody's getting the assessments and, the access if they want it. It's really important work, and kind of wondering what is next, like what are the next frontiers, and looking at this and even sort of, how do we do better? I guess is another question.
Yeah, so for me, the next steps are exploring in detail what the barriers look like and rooting that in people's lived experiences. And so the way that I'm attempting to go about this is through using a digital storytelling methodology and working in particular with Black women to examine what their experiences are, what the barriers are, and using an Afrofuturist framework to center their visions for what needs to change so that there is equity in the care that they receive. So I'll be doing that with community members in the San Francisco Bay Area, and hopefully creating some sort of collective compilation of these lived experiences that speaks power to their truth. And then in terms of what as clinicians we can do better, I think going directly to the communities to provide the care. I think community clinics are so critical. I think it goes back to some of these structural issues. So sometimes people don't have transportation or access to transportation. And so eliminating some of those barriers, I think, is really critical. The other thing is having conversations about some of the modifiable risk factors. I know we didn't have a chance to go into detail about that, but we know that about 40% of risk is modifiable. And so there's work from the Lancet from 2020, I think it's a Livingston et al. Paper that shows that there are a number of things across our life course that we could be doing to mitigate risk. And so as clinicians, I think asking about those things like smoking, physical exercise, diet, et cetera. And so those are things that we can intervene on and educate people about as well. So definitely incorporating that into the clinical evaluation.
This is a good reminder that with links to your papers that you talked about in your presentation and today, I'll also include a link to that Lancet study because it lays it out so clearly. And yeah, it's like it's now a permanent visual in my mind, the literal road to modifiable risk factors. Yeah, thank you for bringing that up. Can you say a little bit more about what like a digital storytelling project looks like, or in your case, it also research, but what that really means?
Mm-hmm. So oftentimes digital stories are focused on a specific topic. It could be about the mundane sort of everyday lived experience. It could have more of a social justice orientation. It's really about what you, as the storyteller lead, want to construct the experience around. But it's a collective of people that have had a lived experience and they record that lived experience. So part of it starts off with just documenting and writing. There's a writing process. You participate in a story circle. So you actually share your lived experience. So whatever the script was that you wrote about that experience with a group. And there's actually a facilitated process where the person shares and has the opportunity to receive feedback from the group. So that's its own sort of process. And I think it's really interesting because as a storyteller, and I'm learning about it myself because I'm going through training, but you're changed as a storyteller just by virtue of sharing, but the listeners and the audience are also changed. And so there's really a healing process that happens in the story circle. And so from there, once you kind of have finalized your script, you start to identify different visuals, different audio that correspond with the story and the narrative that you want to share. And you put it together, you compile it online. And so there's a software that you use and you're taught how to use that. And typically it's more short form content, so anywhere from 3 to 5 minutes total. And so, yeah, that's the process that goes into making it. And sometimes people have screenings where they share everyone's stories collectively. And so that's the goal, ultimately, to have a screening about Black women's experiences of the healthcare system.
Well, that answered my next question, which is you're asking about, or people are going to be sharing their experiences with healthcare, not necessarily about dementia.
I want to do dementia.
Or cognitive.
Or cognitive. So it may not necessarily be dementia, but people pursuing care for cognitive concerns.
That just really sounds amazing. And also just so engaging. And I think, yes, there's just such important voices, but also, in a way, like one thing we so struggle with in caring for people with dementia or any cognitive decline is just, they really do start to become silent in our communities. Like they're just not, their voices aren't heard. Their experiences are, even if they are technically speaking out loud, they're not being listened to. And so I'm really excited to see your work.
Thank you. I'm excited to work with people and to amplify their experiences and their voices.
I want to be respectful of your time, so we'll leave it there. If, and I hope it does, this series continues, I hope we can have you back when you've been in some of that work and can share what you've learned and what you've heard. Thank you so much. This was an incredible conversation. And once again, I'll urge people to take a look at your presentation on our website.
Thank you. Thank you for having me.
Thank you for listening and to our wonderful guests. And thank you to Lisa Costello, our audio editor and voice specialist. We want to make sure you know you can get CE, CME, and MOC credits by going to our website, clicking through to the podcast page, and answering a quick quiz to claim credit. This is all possible through support from the California Department of Healthcare Services and the hard work of our Dementia Care Aware team. If you want to learn more, please visit our website, dementiacareaware.org.